Mastering Urology, High-Yield Clinical Pearls.
Question 14. Picture this. A trauma patient rolls into the ER with a severe pelvic fracture. What's your absolute first-line diagnostic move to safely evaluate or rule out an acute urethral injury? Your options are diagnostic flexible cystoscopy, an excretory intravenous urogram, a non-contrast CT scan of the kidneys, ureters, and bladder, a retrograde urethrogram, or an ultrasound of the bladder and kidneys.
The correct answer is D, a retrograde urethrogram, or RUG. Listen, in any trauma scenario with a pelvic fracture or straddle impact, a RUG takes absolute priority. It's fast, highly accurate, and gives you a literal visual map of any mucosal tears. And here is the absolute golden rule, the Clarence rule. Never, under any circumstances, insert a blind transurethral Foley catheter until this visual map gives you the green light that the urethral wall is completely intact.
Question 15. So what if a male patient is admitted with polytrauma following a high-energy motor vehicle collision, and he's showing an unstable pelvic ring disruption, an expanding pelvic hematoma, and signs of a complete posterior urethral injury? What is the most appropriate immediate urological management? Do you initiate fluid resuscitation alone? Attempt a cautious single pass of a Foley catheter? Perform an immediate insertion of a percutaneous suprapubic cystostomy tube? Or proceed with emergency open surgical exploration? The right move is C, immediate insertion of a percutaneous suprapubic cystostomy tube. If they're hemodynamically unstable, you need to safely divert the urine right now. It's basic primary trauma survey rules. You establish safe bladder drainage to avoid extravasation, and then you step back so the trauma team can literally save their life by managing the skeletal and vascular injuries. Immediate open reconstruction? Completely off the table.
Question 16. In those high-energy pelvic ring fractures we just talked about, which specific segment of the lower urinary tract is actually the most vulnerable to acute anatomical disruption? We're looking at the bulbar urethra, penile urethra, external urethral meatus, membranous urethra, or prostatic urethra. It's D, the membranous urethra. Here's why. This tiny part of the posterior urethra is locked tightly to the unyielding urogenital diaphragm. So when a fractured pelvis creates massive shearing forces, like when pubic rami are displaced, the puboprostatic ligaments tear and yank the prostate and bladder upwards. That differential movement literally snaps the urethra right at the bulbomembranous junction. For the exam, remember this core fact. Straddle fractures involving all 4 pubic rami carry the absolute highest baseline risk for this exact disruption.
Question 17. Let's move anteriorly. A 33-year-old takes a forceful straddle injury, completely tearing the bulbar urethra. Now, if Buck's fascia is also breached, where exactly will the extravasated urine and blood end up on your physical examination? Confined to the penile shaft? Restrained within the superficial perineal pouch and scrotum? Extending into the anterior abdominal wall, scrotum, and mid-thigh? Tracking into the anterior abdominal wall, scrotum, and penile shaft? Or retained within the deep retropubic space? You're going to see it tracking into the anterior abdominal wall, the scrotum, and the penile shaft. Option D. It's all about fascial boundaries. Once Buck's fascia pops, fluid floods the superficial perineal pouch, filling the scrotum and the space around the penis. From there, it tracks straight up the anterior abdominal wall deep to Scarpa's fascia. But, and this is absolutely crucial, it is strictly blocked from going down the thighs by Scarpa's fascial attachments and blocked from the anal triangle because Cole's fascia is fused directly to the perineal membrane.
Question 18. Similar scenario. A 33-year-old male is admitted following a high-speed collision with a pelvic fracture. You examine him and find perineal ecchymosis, an extensive fluid extravasation into the superficial perineal pouch, tracking right under the subcutaneous tissues of the inferior anterior abdominal wall. Which part of the urinary tract has likely ruptured?
You are diagnosing a bulbar urethral tear with a breach of Buck's fascia. Now, wait a minute. Didn't we just say pelvic fractures are historically linked to posterior injuries? Yes, but the physical findings here are purely anterior. This brings us to the signs over associations rule. No matter what the textbook association is for a broken bone, the physical extravasation pattern you see right in front of you always takes diagnostic precedence.
Question 19. Fast forward a bit. Your patient survived the acute trauma, but now has a dense traumatic posterior urethral stricture following a complete membranous disruption. What is the gold standard definitive management option here? Immediate endostopic optical internal urethrotomy? Long-term maintenance with a permanent suprapubic cystotomy? chronic weekly transurethral dilation, or a delayed anastomotic urethroplasty performed 3 to 6 months post-injury?
The gold standard is D, delayed anastomotic urethroplasty performed 3 to 6 months post-injury. It's a strict biological timeline. You absolutely have to wait out this 8 to 12-week period. Why? The hematoma has to organize, local inflammation needs to burn out, and the prostate has to descend back down into proximity with the urogenital diaphragm. Only then can a clean, tension-free anastomosis be successfully performed.
Question 20. Shifting gears to the outpatient clinic. A 30-year-old male presents seeking treatment for erectile dysfunction. For which of the following coexisting ophthalmic conditions is the prescription of oral sildenafil strictly contraindicated? Is it age-related macular degeneration, advanced closed-angle glaucoma, chronic diabetic retinopathy, or retinitis pigmentosa?
The absolute contraindication is D, retinitis pigmentosa. See, oral PDE5 inhibitors like sildenafil aren't perfectly selective. They have an intrinsic cross-reactivity that mildly inhibits PDE6, which is an enzyme in the retina controlling color vision. If a patient has the genetic disease retinitis pigmentosa, inhibiting PDE6 can severely accelerate their vision loss and alter color discrimination. Oh, and while we're talking contraindications, never forget the nitrate rule. Sildenafil combined with organic nitrates is absolutely contraindicated due to life-threatening systemic hypotension.
Question 21. Let's talk infectious disease. Which of the following conditions represents a non-ulcerative, purulent, sexually transmitted disease of the lower genital urinary tract? Granuloma inguinale, primary syphilis, herpes genitalis, or a gonococcal infection?
It's D, gonococcal infection. Gonorrhea gives you that acute urethritis with copious, purulent discharge, but crucially, 0 ulcers. It's super important to mentally matrix out those ulcerative competitors, though. Syphilis, that's a painless chancre, chancroid, deep, really painful ulcers, herpes genitalis, exquisitely painful, ruptured vesicles, and granuloma inguinale, those classic painless, beefy red lesions.
Question 22. If you swab that same purulent gonorrheal discharge, what specific microbiological morphology represents the causative gram-negative pathogen? Is it an encapsulated spirochete, an intracellular filamentous rod, or a kidney-shaped diplococcus? The answer is the kidney-shaped diplococcus. It's the ultimate diagnostic clue for gonorrhea. These gram-negative, kidney or coffee bean-shaped diplococci hiding right inside the cytoplasm of the polymorphonuclear neutrophils.
Question 23. Heading into pediatrics now, which of the following congenital or anatomical penile conditions represents an absolute clinical contraindication to a routine childhood circumcision? Balanitis serotica obliterans, recurrent paraphimosis, severe physiological phimosis, or hypospadias?
You absolutely cannot circumcise a newborn with D. hypospadias. That dorsally incompletely formed hooded prepuce might just look like extra skin, but it is incredibly valuable real estate. It's a fully vascularized tissue reservoir. Pediatric urologists rely heavily on this exact tissue to fashion local skin flaps or grafts during future reconstructive urethroplasties. If you remove it, you've literally thrown away their primary surgical material.
Question 24. Speaking of hypospadias, when a male infant presents with that ventral urethral meatus located on the undersurface of the penile shaft, what is the most common associated developmental anomaly you must immediately screen for? Congenital heart defects, anorectal malformations, structural musculoskeletal anomalies, or disorders of sexual development associated with undescended testes?
The answer is D. Disorders of sexual development associated with undescended testes. The data shows a clear anomaly hierarchy here. Cryptorchidism leads the pack, hitting 7.3% of these kids, followed by congenital heart disease at 5.3%. Finding hypospadias mandates a formal evaluation for underlying disorders of sexual development, especially if the testes are bilaterally impalpable.
Question 25. What is the most appropriate mode of anesthesia for performing an elective therapeutic circumcision in a 6-year-old child? Local subcutaneous infiltration, topical cream, or general anesthesia? The correct answer is general anesthesia. You see, if that child returns for a circumcision at age 6, local blocks just aren't going to cut it anymore. We follow the anesthetic split. Kids between ages 1 and 12 absolutely require general anesthesia. You need complete immobility during the procedure, and frankly, you need to prevent severe psychological trauma. Question 26. Finally, what is the optimal recommended age window for a pediatric urologist to perform definitive surgical reconstruction for a child with congenital hypospadias? Before 2 months, 2 to 4 months, 4 to 6 months, 6 to 10 months, or between 12 and 18 months of age?
The sweet spot is E, exactly between 12 and 18 months of age. Hitting this specific biological and psychological window perfectly leverages favorable penile tissue healing. Crucially, it minimizes the risk of emotional or body image trauma and ensures the anatomical, chordae, and urethral corrections are fully healed long before the child achieves voluntary urinary continence and actually stands up to void.
Mastering these anatomical boundaries ensures you are protecting both function and dignity. Every fascial plane and diagnostic rule we just covered is about making split-second decisions that alter a patient's future. So, when you're faced with that unstable pelvic fracture, ask yourself, are you letting textbook associations dictate your moves, or are you prioritizing immediate safety and letting the physical signs guide you?